think we have everyone. So I'd like to call the meeting to order. It's 10 o'clock in the morning. Good morning, everyone. Our first item on the agenda is to approve the minutes of the meeting held on March 15th, 2016. Do I have any comments on the minutes? I have a few typographical errors, which I will just hand to the stenographer. Dr. Foreman.
I actually just wanted to comment that I found no substantive errors, and I feel like the quality of the minutes is pretty extraordinary, given how hard it is sometimes to follow the conversation. So I say thank you to the stenographer.
I agree, and it also reflects, I think, I'm always struck with how robust and extensive the conversation is from the board, so I want to express my appreciation to the board for that. So we'll turn now to the items on the agenda. On item 2, we have a resolution to approve a notice of adoption to amend Article 13 about laboratories in the New York City Health Code. And this is regarding non-clinical laboratories. The motion was, notice was passed in the City Record on March 25th, published in the City Record on March 25th, 2016. A public hearing was held on April 26th, 2016. There were 5 written public comments and no one testified. I have Dr. Ecclesberg, if you could identify yourself and give us an update on the public hearing.
I'm Joel Ecclesberg. I'm a medical epidemiologist in the Bureau of Communicable Disease, and Dr. Varma and Dr. Rakeman spoke with you in the previous meeting, and they're unavailable today, so I am...
Dr. Ecclesberg, I have to interrupt you because I failed to take a vote to approve the minutes. I apologize to the board, and thank you, Dr. Caro, for your... may I have a motion to approve the minutes?
So moved.
And second? Second. All in favor? Aye. Anyone opposed? The motion carries and the minutes are adopted. Dr. Ecclesberg, please carry on.
Sure. So I'm here this morning to just follow up on this proposal to amend Article 13 regarding high containment research laboratories here in New York City. And just to quickly review the proposal that was presented previously, it would require all high containment research laboratories, which we defined as laboratories that operate under BSL 3 and BSL 4 conditions, to register with the department and also to report certain incidents to us should they occur. Renewal of registrations was suggested to be every 2 years, and at the time of registration a certain amount of information would be required of laboratories, including the name and location of the laboratories, essential contacts, and a listing of all the biological agents that are stored and used there. And the incidents that we also asked to be reported to us are incidents that are also required by the CDC Federal Select Agent Program for laboratories that register with that program, being the theft or loss of agents that are stored or used in the laboratory, exposure to biological agents, or unintentional releases in the laboratory, and reporting to the health department. We suggested that be done within 1 hour. The board approved publication of this proposed rule on March 15th, and there were 7 comments that we received, written comments from academic medical centers by April 26th. And what I've done here is I've compiled really a composite of the comments, because 3 of the letters were very similar, so this is really a distillation of the comments. First one being that the rule should be limited to those high containment research laboratories working with select agents, as this term is defined by CDC's Federal Select Agent Program. And as we described during the March meeting, there are human pathogens that are not defined as select agents that we're also quite concerned about, including MERS and resistant TB and other agents, frankly, that could emerge in the future. We did decide that it would make sense to limit the definition of biological agents to human pathogens, so that if there are laboratories working with pathogens that they discover, for example, that are new animal pathogens that with unknown, or new viruses, say, in animals of unknown pathogenicity, that they not need to report those to us. Also, we decided that all high containment research laboratories would be asked to register and list all of the biological agents that are stored and used in those facilities. Similarly, we were asked to clarify the level of detail needed during registration when listing the agents stored or used in laboratories. And the concern was that a laboratory might actually have quite a number of strains of organisms, and in order to catalog all of the strains that they have, it might be an undue burden on the laboratories. And so we are suggesting that when registering, a laboratory will list all biological agents stored and used and any derivative strains identified by the laboratory that have unique virulence or pathogenic potential. So instead of reams of pages of potential strains for a certain organism, it would be limited to those strains that have unique virulence or pathogenic potential. It was suggested that the registration renewal be changed from 2 to 3 years, and we agreed with that, so that registration would be every 3 years instead of 2 years. There was one comment that was quite common, and it was a request to limit the reporting requirement to within 24 hours of the incident. This was noted to be consistent with the Federal Select Agent Program and communicable disease reporting requirements. But in fact, both the Federal Select Agent Program and our health code respectively require immediate reporting for certain incidents or certain diseases that are identified as requiring immediate reporting to us. We don't define the time, what immediate actually means. So in this rule, we do this by asking the laboratories to report any loss or theft, incident involving loss or theft, within 4 hours of determining that an incident has in fact occurred, that a loss or theft has occurred, which would give them enough time to do their initial fact finding. And similarly, we ask that any incident involving exposure or an unintentional release be reported to us within 1 hour of determining that an incident has occurred. Another comment, reporting requirements should not include pathogens that routinely can be handled in a BSL-2 environment but are being worked with in a BSL-3 environment. And our response is that the department should be informed about all incidents involving theft, loss, exposure, or unintentional release that occur in high containment research laboratories, regardless of the organism that's being worked with. Will inspections occur at registered laboratories? And we will not have an inspection program, but we will respond should there be incidents, and we would field an investigation wherever there is an incident that would be reported. A number of the comments, a number of the letters rather, asked us to clarify the measures that we would take to maintain the confidentiality of the disclosed information and the security of that information. And so a new subsection was added, 13 point 13D, which states that all information, records, and reports will be kept confidential. And disclosure may occur, however, during emergency responses. And the physical security of all information, the records and reports, and their use will meet the standards set by the Federal Select Agent Program. And with that, I think we're done.
Thank you, Dr. Ecclesberg. The presentation's now open for questions. Dr. Foreman.
Thank you very much for the presentation and the responses to the comments. I wanted to press you a little bit on comment number 5, that I saw several of the scientific labs ask questions about, which was that due to space and other limitations, they might store reagents or agents that would not qualify for a level 3 or 4 lab, but because they don't have enough room to have a level 2, they put them in there, that you not require reporting of those agents, that's an administrative burden, presumably lower risk. And your response is, no, we still want everything reported, but I didn't understand why.
You know, the reason being that that there are agents that are worked with in a BSL-2 environment that could still involve a potential risk to the laboratorians. And we are very interested in not only knowing about the agents, but learning about incidents that would represent a problem with the way in which any agent is being worked with in a laboratory. So, for example, if there's an incident involving vaccinia, which actually occurred recently here in New York City, and it was being worked with in a BSL-3 environment, we would still want to know about that, even though it's being stored in that laboratory and even though it's being worked with in that laboratory, because it also is an indication whether or not there's a problem with the way in which routine laboratory procedures are operating in that laboratory, and that would give us an opportunity to have the discussion with the laboratory that we might not otherwise, and that in turn would potentially prevent a worse incident from happening later on.
Thank you, that makes perfect sense, but I just wanted to understand the reasoning. And then there were also, my second comment is, because you addressed the others, is that there was at least 1 or 2, I think 2 of the letters, which were very similar, discussed the risk to privacy, HIPAA. And it was my understanding that it does not violate HIPAA in any way, the transmission of information to the Department of Health, but you didn't specifically reply to that.
Yeah, you know, HIPAA doesn't apply to this at all. HIPAA applies to patient-level information, and we're not talking about patients here. We're talking about research. And to be honest with you, if that was in one of the letters, I must have missed it because I don't remember seeing that, and I probably missed it on purpose. But this, you know, the reality is that HIPAA does not apply in this setting whatsoever. I defer to General Counsel, but I would.
And I agree with you.
If you want to know where it is, it was in the letter from Rockefeller. I guess they used the protected health information, which to me translates to HIPAA. So that was number 7, at least one of the letters, which was very similar, dropped that point for that reason.
You know what I think that might be referring to, I think it might be referring to information that would be reported to us regarding an employee who had been exposed, and that would be patient-level information, and it certainly, would be reportable to us if it would not apply, because it doesn't apply to the health department's mandated activities, and this would be in response to an incident, and it would be very important for us to follow up on.
Yeah, that's what I thought. I just wanted to hear that from you. Thank you.
Thank you, and if I could just note for the record that we've been joined by Dr. Raju, Pam Breyer, Rosa Gill, and Yes. Yes, I mentioned him first. Dr. Raju came in about 10 past and all the others followed. If I could note that for the record, thank you. There was a matter that arose in the minutes from the meeting about our ability to require the reporting of federal facilities in the New York City jurisdiction. If I could ask the General Counsel to follow up for the board.
So, as I suspected, I think I alluded to last time, federal properties under the Supremacy Clause generally are immune from local registration, local regulation. We did follow up with the fire department. I thought maybe it was different for fire codes and that type of thing, but it's not. They do follow model fire codes and federal guidelines, but the federal properties are not regulated by us nor the fire department. And they would not be getting reports, nor could we force them to report to us.
Are there any further questions from the board? If not, may I ask for a motion to adopt? And I have a second. Thank you. All in favor, please say yes.
Aye.
Anyone opposed? The notice is adopted unanimously. Thank you all very much. Thank you, Dr. Ecclesberg. Our next item 3 on the agenda, is a resolution to amend Article 13 of the New York City Health Code. This notice was published in the City Record on March 25th and a public hearing held on April 27th. 2 written public comments together with testimonials were received at the hearing. Do we have anyone speaking to this? Thank you very much. If you could introduce yourselves and state your names for the record. Good morning.
Good morning. I'm Chris DeAndrea. I'm the Director of the Environmental Health Assessment and Communication Program.
I'm Maureen Little. I'm a toxicologist.
You need to turn on your mic.
I'm Maureen Little, and I'm a toxicologist with the same program.
At the hearing in April, we received just 2 questions regarding the proposal to lower the limit, the nuisance level from 100 micrograms per cubic meter to 30 micrograms per cubic meter. They were pertaining to, one question was with regards to the fire code and concern about the mandate for a full sprinkler system when converting equipment from perchloroethylene use to hydrocarbon use. The health code change that we're proposing is not related to this question, and this really is a question for the fire department code, and not one we could answer to. The other question that we received was with regards to the methodology for sampling. The question that was posed to us recommended the use of evacuated canisters to collect samples over a 24-hour period. This methodology is fine, except for that we at the health department want to be present during the sampling period. So a 24-hour sampling would be somewhat prohibitive for us to monitor, and it's also a more costly approach. The state health department performs the analysis for us on our samples. The methodology we use is validated down to 5 micrograms per cubic meter, and we feel that that certainly is more than adequate to measure what we're looking for. That was simply the 2 questions we received.
Thank you very much. Just as a reminder to the board, this will bring our health code into alignment with state regulations. And are there any questions from the board? Can we move on then to a motion to approve the adoption of this notice? So moved and seconded, and all in favor, please.
Aye.
And anyone opposed or abstaining? You abstain. And so we have 1 abstention from Dr. Caro, and the remainder of members present voted yes, including myself. if the motion passes. Thank you very much.
Great, thank you.
The next item, item 4, is a resolution to amend Article 161 and Article 5 of the New York City Health Code that was published in the City Record on March 25th. Public hearing was held on May 10th, and no written public comments were received and no one testified. Good morning. If you could introduce yourselves, state your names for the record.
I'm Mario Molino. I'm the Assistant Commissioner of Veterinary Pest Control at the Health Department.
And Corinne Schiff, Director of Special Projects, Environmental Health Division.
So just to remind everyone, this is an amendment to the Health Code to bring the Health Code into alignment with both state ag and markets law and the administrative code. 2 years ago, the state ag and markets law was changed to remove the preemption that was there that didn't allow us to regulate cat and dog sellers in New York City. Last year, the city enacted Local Law 5, which added additional regulations for cat and dog sellers and put the health department in charge of doing the permitting and inspections. In the health code, where it said where it defined pet shop as for our regulation as not selling cats and dogs, we removed that those words. So now the health code covers cats and dog sellers, and we also changed Article 5 to add in a permit fee, $300 permit fee. And there was a hearing on May 10th, and there were no comments about that.
Are there any questions from the board? We had a discussion about this at our last meeting when it was published for public comment, and the board was asked to approve that. If not, may I have a motion to approve the adoption of this amendment? And second, thank you. All in favor, please say yes. And is that unanimous? The motion is approved unanimously. Thank you very much. So that, the remainder of our the discussion this morning will focus on four proposed resolutions to be approved for publication, and additionally we've added a 9th item to the agenda, a resolution that the board will be asked to approve. If we could then move to item number 5 on the agenda, which is a proposal to amend Article 43. Good morning. If you could identify yourselves for the record.
Good morning. My name is Frank Rasciulo. I'm the Assistant Commissioner for the Bureau of Child Care.
Good morning, I'm Dan Cass, I'm the Deputy Commissioner for Environmental Health.
So we're here today seeking the board's approval for public comment, proposed revisions to Article 43 as well as Article 47. We'll begin with Article 43. Just as a reminder, Article 43 regulates school-based child care programs for children ages 3 through 5. So we're seeking in our proposal to improve the monitoring and reporting of lead content in tap water. In addition, we're looking to update staff immunization requirements and also to require window guards at all 43 facilities. Although no case of lead poisoning has ever been linked to water in a child care center, given recent events, the public is nonetheless concerned. So our proposal would require tap water testing, both for existing schools as well as new schools within 30 days of receiving a filing notice from the department. And we would require retesting every 5 years for all schools. The copy of the results of that testing would be required to be submitted to the department, and of course where elevated levels are found, a plan of corrective action would also have to be submitted for approval. We're also proposing to require window guards or other window limiting devices at all of the programs. We'd have to approve those devices and window guards. and they'd have to be installed on all windows in all rooms, hallways, and stairwells if children under 6 years of age have access. Of course, we would exempt anything used for fire evacuation. My colleague Jane Zucker will speak to the immunization changes.
Dr. Zucker, if you could introduce yourself.
Yes, good morning. I'm Dr. Jane Zucker. I'm the Assistant Commissioner for the Bureau of Immunization at the Health Department. So we're also proposing to update the teacher immunization requirements. And we're doing this because the recommended adult immunization schedule, which is updated annually by the Centers for Disease Control and Prevention, has updated their guidance for what's considered to be immunity for diseases. So what our proposal is doing is aligning the health code with the current ACIP recommendations. And it specifically addresses measles, mumps, and rubella. So we're removing history of illness as being acceptable proof of immunity. And if there is proof of immunity, for example, by laboratory testing, then no vaccine is needed. And there's also no vaccine needed for people who are born on or before December 31st, 1956. And that's just because they likely would have gotten disease at that point. We're also updating the varicella guidance. No vaccine is needed where there's a history of medically documented, and that's important, varicella or herpes zoster, or also if they have laboratory proof of immunity. And then we also want to clarify that we're requiring Tdap vaccine, that's the vaccine with tetanus, diphtheria, and pertussis, instead of TD. The current health code says Tdap or TD, but we very specifically are looking to provide pertussis protection.
So, can I suggest that if you have questions on immunization, we ask them now because the change is the same for 47, and then I'll go through 47 and we can answer both for 43 and 47 together.
Thank you, that's a good idea.
Okay.
People understand that Article 43 is for school-based services and Article 47 is for our childcare, what we often refer to as daycare centers in New York City. So are there questions on the immunization component of this proposed? No questions? Thank you, Dr. Zucker.
Thank you.
So we're now moving on to item number 6, which, is that correct, or?
Do you need to vote on 43
We're going to
first?
vote on 43. Oh, thank you very much. Let's have, are there any questions then on Article 43? Dr. Foreman?
So I did, but it's not immunization related, thank you.
Okay.
Thank you
That's
for that
fine.
presentation. We think the immunization requirements are great.
Yep.
I had a question about the lead testing, actually, which is, from homeowners, or you can get your water tested for free. Who will do this testing and who will pay for it for these centers?
So it's usually done by private contractors. We have at times made the school construction authority available, and the city has paid for some of the testing, but it's normally by private contractors, and the programs would have to pay for the testing.
Is it expensive?
About $700 for a average size facility.
That would be multiple tests, I presume, going around to each distribution.
Right, each faucet that is part of the center.
And my last related question is, you picked 5 years as the time to retest. Why that interval, and does that make sense?
Although we don't think there's a lot of risk to children and that retesting may not be absolutely necessary, we wanted to be consistent with the Department of Education, which is also testing every 5 years.
Dr. Klitzman?
Thank you both. I also have some questions about the lead testing. It's my sense that the risk is probably quite low, but in any event, especially given the recent public concerns, my questions are, what do you anticipate to be the prevalence of exceedances of high levels of lead in the water? And then what kind of recommendations would you make to the operators of these facilities for remediation, corrective action?
So we do have data on positive tests because this has been a requirement of Article 47 for quite a number of years now. So we run at about a 3% positive rate for the facilities. And as far as remediation, flushing is the standard, but programs can also choose to replace faucets and hardware and or add filters.
Thank you.
Thank you. A very appropriate topic, obviously, for the city to deal with. But I'm also wondering, for those few schools that do receive a positive result in the testing, I think that the proposal said remediation plan would be necessary, but is there also a retesting that would happen after the remediation was put in place, other than the 5-year period of time?
Yeah, so upon a positive test, we do provide complete guidelines on how to deal with an elevated level of lead and water. In addition, I'm sorry, state your question again?
Retesting, would there be a,
Oh,
a
yes,
follow-up
so in
test?
addition, within 2 to 48 days, we require retesting to determine whether or not we in fact have addressed the problem. Because it could be in any part of the line, it could be in the faucet, it could be midline, or it could be deeply into the building. So we do the three-draw test after the first positive.
Thank you.
Let me just add it. I just want to add. I want to keep adding. So I just wanted to add that a little bit more about what the retest is designed to do. So an initial test is typically referred to as a 2-draw test. After a period of 8 or more hours of stagnant water in the line or the facility, the first draw test is literally the first water that comes out of a tap. That is designed to evaluate a worst-case scenario. So lead would leach from any fixture or line into the water and then be detected, if it's detected. At the same time, we take a second draw after about a 30-second to 1 minute flow of water from the fixture. That gives us some sense of whether a high level on the first is actually declining by the time the second goes. If those are high, and if either of those are high, the retest involves a third draw. So we do it exactly the same way before, a period of stagnant water, a first draw, a second draw, 30 seconds to a minute later, and then we let the water run for 10 minutes, and we do a third draw. That evaluates the efficacy, or the effectiveness rather, of whether flushing works. And I should just note that these tests are really designed to capture a true worst-case scenario, because water is used over the course of a day, over the course of a week, and effectively water is flushed throughout a week in any kind of facility. So these are really designed to take sort of highly cautious and preventive actions, at any detection whatsoever of elevated level.
And can you clarify the protocol for retesting the water if it has remained high after remediation?
If there were an instance, and I don't think there has been, but if there were an instance where the third draw showed that levels remained above 15 parts per billion, what that would tell us is that flushing alone is insufficient to reduce the risks. And at that point, the corrective action plan would require a deeper investigation as to the source. It would require fixture replacement, potential plumbing changes.
Thank you. Dr. Richardson.
Yeah, thank you for the information. In the event, and perhaps you can speak to your experience under Article 47, that there is a positive test, is there any notification or screening of the children in the facility where this high level has now been detected? How is that handled?
So again, we've never traced high levels of lead in a child back to a child care facility. We are notified. The department does go out and check all facilities prior to the latest news. We've already had a process in place for following up the child care centers, and we've never determined the center to be the source of the increased lead in a child. As far as notification, if you're speaking to parents and guardians, we are considering now when a parent should be notified or guardian should be notified of a high lead level and how much information we should really share. I mean, we're not looking to start a panic over something that is really minimally risky to children, but we do think they need to be informed. So we're drafting out a number of templates depending on if a program is flushing or they've done a complete remediation by replacing hardware. And decisions need to be made around when the parent is notified. We're thinking right now after the third draw test, the second test, especially when they're flushing, so we can at least say, it's been addressed. So yeah, it's under consideration, and we will most likely be notifying parents.
Dr. Foreman?
Thank you. I just wanted to add one other comment. I strongly encourage the department to notify parents, even though I agree the risk is extremely small. Parents will ask questions like, okay, so you determined that there was lead in the water and you've remediated it now, but my child's been in this school for a year, how much lead were they exposed to? And most likely, a blood lead level would be very reassuring. They're very easy to do. We do them routinely on children that age. There may already be a level existing, and I think parents would be distraught if they felt that that information had been in any way withheld. So I think if you phrase it well, it won't engender panic. And on the contrary, I think that if it is in any way withheld or delayed or spun, then you're more likely to encounter problems with families and parents and with the rest. So I think quick disclosure with appropriate guidance as to how low the risk is makes much more sense.
Thank you.
Thanks for that comment. Are there any further questions from the board? The board is aware, I'm sure, of the recommended screening protocol for blood lead levels in New York City, so I won't go over that with you, Dr. Klitzman.
I also wonder if you think it would be helpful in your educational materials to summarize the points that you made earlier, that in the department's extensive history of testing and in monitoring test results, you've never found a facility where the levels remained high after the flushing and retesting procedure, and have never linked a case of childhood lead poisoning to a water source in a child care facility.
Thank you. I think that's sort of sage advice. We have been clear over the last several months as stories have continued to arise and questions asked about lead and water in New York City generally, and schools more specifically. And we have tried to make that point, but I think you're right, it does belong in education materials.
Thank you. So this was a discussion of the lead, the amendment regarding lead testing of water in the Article 43 facilities, but much of this conversation, I think, was also relevant to the proposed changes to Article 47. Let us proceed then with the article, yes, with the vote on Article 43. This, again, to remind the board, is approval for publication. That will be followed by a period of public comment where I expect some of the questions that Dr. Foreman will raise will also be addressed.
Move the approval for publication.
Second.
All in favor?
Aye.
And anyone opposed or abstaining? No, the motion to approve for publication is passed unanimously. Let us move on now to the proposed resolution to amend Article 47 for the child care centers regulated under the health code in New York City.
Okay, so we're looking to approve a number of the provisions in 47, some around lead content also, but others around enhanced enforcement tools for poor performing centers, the improved oversight of teacher training and certification, increased transparency of inspection and findings for parents, as well as updated fire safety requirements, clarification on clarifying requirements for enabling access for outside support service personnel, and aligning teacher immunization mandates with the new CDC recommendations, which is exactly mimics the one that was proposed for 43.
Thank you very much. Open now for questions from the board.
I think there's
more.
Is there more?
Yeah, it's, I
Keep going.
Yeah, so as I said, in 47, we've had a lead water test requirement for a number of years now. However, all the code requires is that programs test and that they remediate. There is no requirement for reporting back to the department the results of that test, nor is there a requirement for CAP submission. And there were no timeframes for when programs need to do the test. So we're putting some structure around that. Basically, all existing permittees, if they haven't already tested, would have to do so on the effective date. If it should be approved, new permittees would have to conduct a test within 30 days of receiving their permit. All centers, again, would have to test every 5 years. And copies of the test results will need to be submitted to the department for review, and any elevated levels in programs would have to be come along with a CAP submission for review and approval. We're also looking to set a standard, to create a standard for permit revocation in the code. Currently, the code is very clear as to when we must suspend a program. Basically, if there's an imminent health hazard that can't be complied with within 24 hours, a suspension is necessary. It goes further to define imminent health hazards. But the code is silent on revocation. So suspension is basically a temporary closure. Revocation is a permanent closure. So there's nothing really in the code that says when we should consider revocation of a program. So these provisions would lay out some of the things to be considered and the conditions to be considered when we're making a decision around revocation. And we've named a few here. So if there's more than one prior suspension within 36 months, if a prior suspension involves a lost child or inadequate supervision, inappropriate behavioral management issues, a failure to implement corrective action plan when required, or continuing to operate with suspended permit when ordered to close. Also, if they're unable or unwilling to correct patterns of serious repeated violations. Of course, revocation is heard at oath. It's not done internally, so there's a third party overlooking and shepherding the process and trying to make the decisions. We think this standard would also help both make their decisions, because we're often asked to just step out an agreement without true consideration for whether or not, based on the history of a program and the current conditions, whether or not that program should continue to operate. Oh, sorry. And if we do revoke a permit, we would prohibit a new application for permit for a period of at least 5 years. We would also be mandating participation in our performance improvement initiative. The performance improvement initiative was launched back in March of 2015 and is designed to improve compliance among programs with repeated violations. They receive intensive technical assistance and case management one-on-one for a number of months to help them improve their performance. The unit deals with some of the worst performers in the city, and it makes an effort to help them improve the quality of the services that children are receiving. Up till now, participation has not been mandated, but we've seen enough risk in some of these programs where we feel it should be a mandated part of the process. And a true evaluation and assessment made of the services that they're providing to kids to, one, make a determination as to whether or not they should be revoked. If that's true, we would go to oath with these programs, but if not, if we feel that there is a way to bring these programs into compliance and to systemically improve their performance, that's the goal of this new unit. So it would require a corrective action plan, and it would establish the contents of the corrective action plan. It addresses their history of violations and conditions and any health hazards that they've been cited for in the past. We identify those causes, and we basically provide the programs with a profile of their performance over a 3-year period of time. And then we work with them intensely on trying to improve systemically the services and the conditions that are causing, poor service delivery.
That's scary. In the last year and a half.
We still have a little more to go.
I'm sorry.
I think. So,
Fine.
yes,
Finish.
I appreciate this. This is a
Sorry.
rather long list of amendments. So if you could just note
I
your
will.
question
I
and
will.
we'll return
We're also looking to enhance our enforcement tools around fraud prevention. And to help prevent fraud, we would require submission of the New York State identification number upon application for a permit, as well as for any employees of a facility. The NYSED number is something that staff receive when they're fingerprinted for criminal clearance. It's already a requirement of the code, and all of the staff in the system at these programs are assigned NYSED numbers. We'd like to use that NYSED number as a unique identifier to get a better sense of the number of programs that individuals operate, what the history of those programs are. It's just a way to really say who's who in the system. We've had a number of cases in the past where we've had false claims about who were employed, fabricated staff credentials, and also document submitting, substituting staff identities. So this is just a way for us to know who's who in a child care facility. Often when we arrive on site, we look at their records and we find records with credentialed staff and clearances, But we have no way of tying that record to the individual in the classroom. We really don't know who's who. So this would help us to move towards having a better sense of who's working in our facilities, what their backgrounds are, and more importantly, for people that operate multiple sites, we'll be able to know who the people are. Often they'll just incorporate, and we have no sense that, this is the same person that operated a program 2 years ago that was very problematic. So using the NICED number, we believe, is the best way to sort of identify these people and at least assess and evaluate how they provided services to children and whether or not it's safe. We're also looking to improve teacher oversight around training and certification. There's already requirements in the health code for educational requirements and ongoing training, but this is largely a paper-based process, so documentation and certification is submitted to the department, or we review that documentation when we're on site. It's extremely burdensome to teachers, it's disruptive to centers when we arrive and we need to look at all of their records for all of their teachers. And it's also really not a very efficient process for inspecting and overseeing the system. So we'd like to move to an electronic submission of training and certification of all of these documents and to house them into a new data set that would be managed and maintained by a third party. So we're essentially just moving from a paper-based system for certification and training to an electronic system so we can better analyze and really know what the qualification level is of the staff in these facilities, and it will also enable us to better track study plan. We'd also like to improve the provision around educational director vacancies. The educational director is responsible for curricula, they're responsible for training teachers, ensuring the daily compliance with the health code. A consistent presence of the ed director is extremely important, and it's critical to quality and safe care of children. So we're proposing that in the absence of a director, a certified teacher only be designated as the acting director. Currently, the code's unclear that individual who's covering for the director needs to be certified. So we do have a lot of cases where we have a teacher who's on study plan with no degrees in early childhood, working towards it, but no degrees in early childhood covering for the ed director. It's really too important a position to leave to a person who's on study plan, so we'd like to make that change. We'd also like to know from the program when a director is terminated or resigns. Often we don't know, we don't catch up with it for a year or so. Upon another inspection, we suddenly find out that, director has left, an educational director has left, a year prior, and it's been operating, the program's been operating without one for that entire time. We would also require permittees to give written notice to staff when an ed director is going to be out for more than 5 days, so that the staff know who's covering for the ed director. We're really trying to place the, or enlighten programs as to the importance of, educational directors and the need to have them on site. Through some data analysis, we found that programs who don't have an educational director have a higher rate of citation and have a higher rate of staff turnover. So we want to put some structure around, more so than what's in the program, in the health code now, as to when they need to notify us regarding termination or resignation and who is covering. There's also a need to increase transparency for parents. Currently, Article 47 requires a permit to be posted near the entrance. Our proposal would specify that the permit must be posted at the front door and must be encased in a protective frame. What this really speaks to is illegal childcare. We want to emphasize with parents the need for programs to be licensed and what it means for a program to be licensed. So it might seem like a slight change, insignificant change, but we think that seeing the permit on the front door would really drive home the message that this is a permitted site, and if you're not seeing it, you need to report it back to the department so we can follow up and make sure that the site is appropriately permitted. We'll also be doing a media campaign around this through our Child Care Connect system to emphasize the importance of licensing and what a license means for a child care program. We're also proposing an update for fire safety requirements in the code. Currently, the health code requires fire alarms when a program services more than 30 children. Proposal would require the fire department approved interior alarm systems for all centers. And this just brings us into consistency with the building code. Building code changed back in 2014, and it now requires fire alarms for 5 or more children. So we're just making it consistent, and this would apply to new centers or centers undergoing extensive renovation. We wouldn't go retroactively with it. We're also requiring, again, to be consistent with the building code, sprinkler systems for infant and toddler programs. We also need to clarify access for support service personnel. Although the ADA requires access to children with special needs by outside personnel, it's not specifically stated in the health code. It requires, the programs are currently required to range from fingerprinting and clearances through state central registry of abuse and maltreatment for all staff, volunteers, and contractors. There's provision in the code that allows those contractors to be without clearance as long as they're on direct line supervision. So this proposal clarifies that the centers must allow early intervention and committee for preschool special ed providers to deliver services to children, so they must allow the access, and that the center need not conduct SCR or fingerprint clearances for those staff. And then this is just the immunization requirements that we've already discussed for 43, so. Question?
Thank you, Mr. Paschullo. The program in putting together that's rather large, I believe it's 11 in all, it's a large number of actions, are really aiming to improve the safety and quality of our child care services in the city. So it is now open for questions from the board.
So, my colleagues around the table have forgotten more about childcare than I probably know now, but let me just say that I certainly applaud this effort. I guess I'm a little surprised that some of these things aren't already in the code. And I've been on this board a long time, and I guess I was lulled into some sense of complacency about the level of rigor, so this is really great. So I have just 2 questions. One is, you mentioned earlier the collection of data online, sort of given to a third party. What's the third party? What did you mean by that?
So we're seeking to contract that process, the qualification process, review and approval of quals and training to CUNY Professional Development Institute. They have the Aspire system that the state and the city has funded, and we're looking to them towards using that system.
Right. So over the last year or 2, you may not know the answer, how many, first of all, how many of these programs exist in the city? We don't really even know, do we? Or you know,
No, we
how
don't.
many are licensed? How many are licensed?
We have roughly 2,300 childcare centers.
And how many permits have you revoked in the last year or 2?
Very, very few. I've been here since '05. We've probably revoked 4 programs in that period of time. It's a very serious action. We don't take it lightly, but we do think the code needs to speak to a standard for revocation.
And so do I, so good for you.
Ms. Red Leonard.
This is obviously a very important topic, and I think, we all support the safety and quality of the environments that young children are in. My question, I have a couple of questions. These regulations apply to childcare centers regardless of their size. Could you speak a little bit to the range of size of daycare in general in the city?
Sure, so it applies to any sort of commercial, non-residential childcare service with 3 or more children. Like I said, there's 2,300 centers. There's about seat capacity of about 160,000 seats. The average size of a preschool, and that's ages 2 through 5, is about 45 children. The average size of an infant toddler is about 25 children. Unless we're talking about publicly subsidized centers, they're much larger. I don't have the exact average, but, you know, your ACS contracted sites would be much larger organizations. You're probably talking to 100 to 200 children in those sites.
So you say that the regulations apply to non-residential daycare. So there's a whole other category of residential daycare that
Yes.
is treated.
So there's family daycare, group family daycare, and then there's after-school programs. Those are regulated by the state, Office of Children and Family Services. We at Health have a contract with the state, so we do all the monitoring and licensing of those programs and the inspections. But the health code does not regulate home-based care.
Home-based.
Right.
And so the state has regulations for that. So are there similar regulations in home-based daycare, or is it modified based on, you know?
So there's similar regulations around clearances, of course, you know, the need for a medical review, references. Where it differs is along the lines of credentials. You know, there really aren't any credentials for home-based providers. There's no square footage requirements for home-based care as there is for center care. So they're very consistent around the basic health and safety requirements, but then they diverge again along, you know, your credentialing and training and all of that. So.
Right. I mean, it's just an interesting challenge, I think, because I'm concerned a little bit about the affordability of daycare for families. You know, it's very difficult for low-income families to find good quality daycare. And, you know, the idea of an educational director being required regardless of the size, it's, you know, important and good, but, you know, I'm just trying to, I think we need to also balance the requirements, the administrative burden, and what that does in terms of the cost of the program and parents' ability to pay for.
Right. We're very much aware of it. You know, we've done a lot of analysis around infant toddler care in the center-based programs, and there's an awful lot of turnover in infant toddler care. A lot of them go out of business. Of course, it's probably the space requirements. They need to be on the first floor of a commercial building, which is the most expensive part. But we are looking at, for future revision, the role of the ed director and whether or not we should consider allowing a span of control for smaller facilities. So if you operate 4 facilities, an average size of 25 children, should we allow a span of control for the ed director to be overall 4? I mean, we're considering a lot of issues around the qualifications and how we can reduce the cost, which, again, we're very much aware of it. We're not ready to propose anything yet, and we would definitely, you know, include DOE, ACS, and the other stakeholders in the city around that conversation.
Thank you.
And just to be clear, the requirement for the educational director is already part of the health code. What's being proposed as an amendment is that we keep better track of whether they have been terminated or resigned and have left the site. Dr. Richardson.
Yeah, if you could go to the second to last slide. I did not follow what the current situation is and what the proposed change is. This was around the, yes, access for support services personnel. One more time, please.
Sure. So one issue that's come up over the years is access. Programs refusing to allow access of these staff to kids who need special education services. And these staff are early intervention staff, they're CPSE staff, they're CEIT staff.
Who come from where?
Who are basically contracted through DOH and contracted through DOE, but are provided by private, not-for-profit companies.
Just to clarify, these are professionals attached to individual children and that use the center as a place where they provide services.
So one of the concerns had been whether or not they had been appropriately cleared to be in childcare settings, and they are through their approval as EI providers or as special ed providers.
Right.
So it would be redundant to require
Right,
additional-
so, yeah, largely they're fully cleared by the requirements through state, Office of Children and Family Services and state education department. There's some differences in the clearance levels that we're in discussions with now to make a determination as to exactly who's cleared for what. But I can tell you that the CPSC staff and the EI staff are fully cleared, meaning that they have full criminal background and they have full SER background checks. The CIT staff are fully criminally cleared. They're basically managed by DOE
Right.
through their PET system. The question here is whether or not they're SER cleared, and that's something that's under discussion now.
All right, so this basically relieves the centers of the burdens of having to clear them,
Right,
what
clear them.
requires access.
That burden and also maintaining a record for them, so.
Dr. Caro, followed by Dr. Foreman.
Yes, I understand that this, no matter the size of the child care service, 3 to 5 or more, that's number one. And number two, is there a time span limit on the correction of any finding on each case? Is there a limitation of time that they have to correct?
For the lead.
For each of them, lead and...
Any corrective action plan?
Yes.
So normally we require a corrective action plan to be submitted in 5 days for review and approval. But for lead, we take more immediate action, but the programs technically have the 5 days to submit their plan.
I think to your question of what kind of tolerance we have for progress, that's evaluated over time. So corrective action plans, let's say for a center that's enrolled in the Performance Improvement Initiative, that involves a series of milestones and steady progress. We provide ongoing technical assistance, case management, we have a physical presence in the center with greater frequency than we would from a normal inspectional program, and what we would expect is that systems are in place and actions are taken over time.
Dr. Foreman.
Thank you very much for a lot of very positive changes. I actually have a question that follows up on the performance improvement program and the mandate that centers that are, I think the wording was below standards, must participate. And just in keeping in mind the burden and costs, I'm curious what percentage of the permittees fall below standards, and how costly is this for programs to participate? Not that it sounds like a very important process, but I'm just curious how large it would be.
So basically, we broke up the city into 4 categories, 1 and 2 being the best performers, 3 being sort of your average performers, and then the 4th category being the worst performers. I mean, right now, we're working with about 24 programs. Certainly, there are a few more that we need to work with as we sort of build capacity. Cost is dependent upon the systemic issues that got them into the program. If they don't have an ed director, sure, it's going to cost them more to come into compliance and to fix their program because it's a big hire for them, and they often don't want to pay the salary. This is why they don't have the ed director. Some of it is just sort of the administration of the program. Things like clearances. We have a requirement, it's the most stringent in the entire state, that you SER clear your staff every 2 years. A lot of programs we find try to manage this on all different days, like 2 years from the date that the person was hired, instead of just having a clearance day, clearing everyone and moving on. So a lot of our violations occur because they're not saying, so it's things like that, it's systemic sort of operational things that we try to work with them on, and there's no cost to that. It's just really, we're functioning as a consultant on their operations. So and I can't answer your question because there's so many different things that get these programs into, if you don't criminally clear your staff, and that's why you're in this program, there's a cost to that. And it is costly to do that, but that's needed and required, so.
Can I follow up with one?
Yes, please.
You mentioned that there were very few revocations in all the years you've been here. How about suspensions? How common is that?
So we suspend about 30 programs per year. Okay.
Thank you.
And the vast majority reopen.
First, Ms. Breyer,
So
Breadliner.
on the premise that you will be busier once this is approved than you are now, and you may need more staff to do this, this has been factored into consideration, and we're reasonably sure that no one would want this to be on the books really without the adequate staff to do it, right? I think you'll need more staff, no?
So again, the Program Improvement Initiative has been in place now since March of 2015, the city has funded the additional staffing for the unit. They've also just funded a initiative for risk management along the lines of PII.
Good.
So that would increase the number of inspections. So I think we're staffed adequately.
I do want to add also that we have sort of made announcements publicly over the last several months that we've added a substantial number of inspectors to our workforce. We are moving to a risk-based inspection program where those programs that have greater violations will be inspected with greater frequency, and we have obtained the staff to do that.
That was related a little bit to my question. So how often are the daycare facilities inspected, and evaluated relative to these measures? Is annually?
And normally, we do annual inspections. So like I said, there's about 2,300 centers, and last fiscal year we conducted 9,000 inspections. So we're committed to going out annually, but many of these programs get many more inspections.
And just wondering if the ratings are made public in any way for parents to know?
They are not, but we have, at the same time that we launched PII in March of 2015, we launched a new profile page, performance profile page on our website that identifies key sort of performance standards and compares those standards to citywide averages. So a parent who signs up for Child Care Connect or just goes to our website and goes to their child's center, the first thing they'll see are these performance standards when the page opens up. And it gives them a good sense of, the performance of the center in comparison to the city at large. Yeah.
Thank you.
And do you want to say anything about the proposed report card from the legislature?
Yes.
Just for the interest of the board.
There's been a bill introduced by Senator Klein in the state Senate. That bill would require city child care centers to post a performance card, which very much would be based on some variance of the data that we currently put up on Child Care Connect. It would advantage parents by not requiring them to go to a website, but to have information at the point of entry in a way that's sort of similar to something like restaurant grading, where consumers have information, and just as importantly, the businesses know that consumers have information.
This wouldn't be just for New York City.
I think it's written as it would be for New York City.
Yeah, that's to be determined by the legislature.
And Ms. Klitzman, Dr. Klitzman, excuse me.
What sort of training, outreach, or technical assistance do you think might be needed for operators to be able to be in compliance with these new regulations if they're promulgated?
I think a lot of this is just sort of building on what the requirements already are. Like I said, I think a lot of it comes down to having them look at their service delivery in a different way, and to identify, once we identify for them, the problems that they're having, I think it makes it easier for them to address them. So I don't know that there's a lot of training that would be required there. If we move towards, if it gets approved, the electronic database, there will be some training required for that, and we'll work with, PDI and training programs on how to sort of create their accounts and enter their staff. We'll give them plenty of time to comply with the requirement. We're willing to give them 2 years if necessary, because it is a very big system. We're talking about 22,000 teachers. And we will, like I said, give them a lot of technical assistance. But the good thing is that once we have it in electronic format, it's very easy for a teacher to move their credentials and potentially their clearances if we make that part of the system and move to a different facility. It's going to give us a lot of good information on turnover. Right now, everybody believes there's a very high turnover rate in childcare. But we don't know if that's people actually leaving the system or just moving to a different center. We don't have that data. So this will give us a lot of good data on that. It'll really help us professionalize the field if we can get this passed.
Thank you. And Ms. Naowith.
Frank, I'm going to call you Frank because I never call you by your last name. But I do want to say that this is a significant shift, positive, long overdue, many people would feel. So I congratulate you for that, and also the subject of countless reports that I have either written or I have had to participate in committees about. So the conforming changes are very important, and I think it also reflects the city's commitment to young children and their education and safety in a way that parents cannot possibly do on their own. So I just want to say thank you.
Thank you, I take that as a comment, not a... And I would also note that the city remains pioneering in this regard. Are there any further questions or comments from the board? Then in which case I will ask for a motion to approve for publication. Item number 6, the proposed resolution to amend Article 47. May I have a motion? Approve, second, and everyone in favor, please say yes.
Aye.
No one either opposed or abstaining. The motion carries unanimously. Thank you very much. I'd like to note that Dr. Richardson is going to need to leave now for a prior engagement. We have a quorum, and thank you very much for joining us today. Let us move on then to the proposed item number 7 on the agenda, the proposed resolution to repeal sections 139.07 and 05 of Article 39 and section 153.01 of Article 153, section of Article 181, as they are no longer needed. This is a proposal for publication.
And I'm going to be the presenter on this one. So we will occasionally go through the health code and we will look at sections that are, and come to the board and ask the board to repeal sections that we feel are no longer needed, either because they are archaic or because they are redundant, especially if they are regulating conduct that's covered by other laws and rules. And from an enforcement standpoint, it's not good to have multiple laws that cover the same conduct because it can lead to inconsistent and confusing enforcement. So today we're going to ask you to repeal 4 sections of the health code that regulate 3 activities that are regulated elsewhere. Sections 139.05 and section 153.01 of the health code both address littering. Littering is primarily enforced by the Department of Sanitation. It's covered by Administrative Code Title 16, and that's the section that the Sanitation Department is going to cite. There's no need for these articles, and we're going to ask you to repeal them because they're redundant. Article 181.03 regulates spitting. This has not been enforced by the department other than me against my son in the last, in my lifetime. But similarly, Title 16 of the Administrative Code covers spitting. It's been recently amended to cover spitting and littering in public. I should have said littering as well in transportation centers, which was a gap that existed before that recent amendment. So again, there's no need for the sanitation department or police department or other departments to cite this health code provision because they can cite the administrative code. And the final section is 139.07, which regulates smoking at public transportation centers. This we've kept on the books for a while because there was at one point a gap. As most of you know, we enforce smoking along with other agencies, but we primarily enforce 2 different laws. The Smoke-Free Air Act, which is the city's smoking regulations, and the State Clean Indoor Air Act. Both of those now cover transportation facilities, so again, there's no need for this provision. In fact, we don't cite it. When we go out and do Smoke-Free Air Act enforcement, we cite, as I said, either the State Clean Indoor Air Act or the local Smoke-Free Air Act. And so we're going to ask you to repeal this is for publication, but the proposal is to repeal these 4 sections as redundant and no longer needed. Any questions?
May I have a motion then to approve publication this revision of our code? And all in favor?
Aye.
Thank you. I take it passes unanimously. Thank you, Mr. Mayor. So we're moving on to the proposed resolution to amend Article 161. This again is an approval for publication.
Yes, and this again is me presenting. Many of you received a letter from a constituent, a resident of Stuyvesant Town, which some of you brought to our attention, and this is in response to that letter. The constituent raised an issue and alerted us to a possible gap in the Cooper Scooper laws. So the gap being that as written, although I don't think it was the intent, but as written, it's unclear whether the health code provision 161.03, which makes it illegal to allow your dog to create a nuisance, which is pooping, in public space, would apply to Stuyvesant Town and other places like Sicardi Park, which are public space but privately owned. And so this amendment, we saw the letter that you brought to our attention, and again, I think the intent was to always cover public space, whether it was privately owned or publicly owned. But this amendment would, in response to that letter, would propose amending the health code to make clear that the nuisance prohibition for animals applies when you're outside walking along a public space, whether it's public street owned by the city of New York, or a public street, a street open to the public owned by Stuyvesant Town or Sicardi Park or some other place like that. So any other questions?
Is the citizen who brought this to our attention aware of this change?
He is aware of the change. I'm not sure if he's here today, but he is definitely going to be at the public comment period, or a comment, and then he may be at the hearing as well.
Thank you.
Are there any other questions, comments from the board? May I have a motion?
I'd just like to note that I think it's very impressive that an individual, one letter being sent to the Board of Health gets a proper review of the code and this kind of response. I think that's very, very appropriate.
Thank you. All right, then may we move on then to a motion? May I have a second? And all in favor?
Aye.
Passes unanimously. Thank you very much. We have one additional item to ask the board to approve a resolution.
And my third, I got the string here, the turkey, 3 in a row. All right. So in addition to rulemaking, the board under the administrative code has the ability to declare a condition to a widespread nuisance. This is pursuant to section 17-148 of the health code. We've done this in the past. For those of you who are on the board, in 2004 we did it with West Nile virus. We've done it with rats over the years. We did it most recently with K2 sales in the city, but primarily in Harlem about 2-3 years ago. What the administrative code allows is the commissioner has nuisance authority. She can go out and declare something to be a nuisance, but if it's widespread, then doing individual orders and having them served can become quite burdensome and also prove to be ineffective because there's a delay. So when there's a condition that is widespread, the board, and the examples in the statute are ragweed or pollen or any sort of plants like that, but it can also be, again, conditions that harbor rats, conditions that allow standing water to exist. The board can pass a resolution declaring those conditions to be a nuisance and directing all owners of property in the city to abate the condition. And then rather than having to serve every individual owner or that you want to have abate the nuisance, you can publish it in the city record and publish it in 2 papers. And then that is deemed service by publication, and every owner in the city is on notice and is directed to abate the condition. What we're asking you today, and the resolution was in your package, but it based on the presentation that you had on Zika last time, it would direct that owners of land, it would declare certain things to be a nuisance, primarily debris, uncleaned lots, standing water, any sort of debris where water might collect, and it would direct owners to abate those conditions. And part of the statute is that we're supposed to supply information about the widespread nature. There was the presentation last time about the particular mosquito in New York City that is here that might turn into or possibly could turn into an infective vector. By way of background, the city does each year, the department each year does issue 600 or so NOVs to landowners for standing water violations. And with other agencies, the city does clean up approximately 3,000 lots for conditions that can harbor pests. So it is a widespread condition, and the fact, what this will do is we will publish this resolution if you pass it in the city record and in the media, and it will thereby declare those conditions that will allow water to gather and this particular mosquito to possibly breed, to be nuisances, and direct that those conditions be corrected.
Are there any questions or discussion of this request? Just as way of background, we've had many more complaints of standing water this year, and we're happy to have received them.
Just wondering, is there a fine or some sort of consequence for people where this is a violation?
So there are a couple possible different routes. So yes, there can be a fine, there can be what's called a notice of violation issued for standing water under the health code anyway, and we do that about 600 times a year. We may do that more this year. But what can also happen is if you violate this order, and if we reach the point where Zika is being spread, and it's not there yet, but if that did happen, this order would then be a predicate for the city then going in, and if people had refused to comply with it, the city could then go in and get access orders and do the work itself, and this is a predicate for that. And then there would be liens for the cost that the city incurred as well. So those are the possible routes.
Dr. Carroll.
And the source of the citizen called 311 or?
No, this was not, the last one was, I'm sorry, the complaints?
Yes,
The complaints are, yes, we ask you to call 311, but this basically enables us to have a sweeping city-wide order rather than have having the burden of going individually to serve orders on one by one based on complaints. So it would greatly enhance our position to respond rapidly and with agility if the need should arise.
I think it's a great idea. I'm just wondering about, you said that you just publish the notification and then building owners are supposed to know about it, but I'm just wondering if there's a way to increase public awareness about, the expectation that all building owners should comply and, be citizen, watchdogs or whatever.
I speak as a lawyer and not as a Dan Cass program guy, so I'm talking about the bare legal requirements for the service. I absolutely agree with you, and I think the program would as well. And in fact, actually, we probably have been putting this information out already. And I agree with you. This will also be on our website, and we will do everything we can to educate people about the fact that not only should they be cleaning these conditions up, but now that there's an order to do so.
And if you need to reintroduce yourself, I think, to speak to this matter.
I'm Dan Cass, the program guy. Deputy Commissioner for Environmental Health. So we agree, we do presentations to Building Owners Association, Building Management Associations, the Real Estate Board of New York. We do sort of really impress on them the importance of standing water control. We do presentations where we know standing water is likely to occur. So for example, prior to the beginning of the mosquito season, we meet with all of the funeral, the cemetery directors across the city where we remind them of restrictions on flower pots and what to do about that. In addition, we have an ad campaign going on right now about Zika, Fight Back NYC, where we really do try to highlight standing water. And if you are anything like me or have the right sort of friends or connections on Twitter and Facebook and stuff, you'll be getting, repeated entreaties to control standing water as well. So there is sort of quite a bit of outreach. At the beginning of the mosquito season each year, we send a reminder letter to anyone who got a notice of violation the prior year that they're on notice that you had this problem last time. We don't want you to have it again. So I think we're really committed to doing outreach.
Great, thank you.
Thank you. Are there any further questions from the board? May I have a motion then to adopt this resolution and a second? And all in favor, please say yes.
Yes.
All right, I take that it passes unanimously. Thank you very much, the board. We're now going to move on to a presentation. Earlier, the board approved a measure to make first episode psychosis reportable Our intention the board's intention, I wasn't commissioner at the time, was to try and ensure that we provide more rapid entry into care for people who are usually young people who have these first episodes. And we thought it would be useful to the board and to hear how it's going. So we're going to have a presentation about that. This, of course, is in line with the city's really very robust commitment to the improvement of access to mental health services in our city. If you could introduce yourselves.
Hi there, I'm Dr. Myla Harrison. I'm Assistant Commissioner in the Bureau of Mental Health.
And hi, I'm Dan Anderson, and I'm the director of the New York City Supportive Transition and Recovery Team, which is the program that manages the first episode psychosis reports and response. So to give a very brief overview, in 2013, actually, the Board of Health approved an amendment to Section 1104, I believe was added to the Health Code, making hospitals required to report to the Department of Health and Mental Hygiene individuals between ages of 18 and 30 admitted to a hospital with a first episode of psychosis. That amendment went into effect in 2014 and led to the creation of a response program as well to offer services to those individuals, a linkage to care team. So it allowed the OMH to offer services to improve linkage to care via the NYC START program, the Supportive Transition and Recovery Team. To date, over 70% of individuals who have been referred to this program have accepted the services, which are voluntary, of the New York City Supportive Transition and Recovery Team. And of those, nearly 75% have attended an initial outpatient mental health appointment within 30 days of their hospital discharge. A number that I highlight because it's significantly better than the average of people leaving an inpatient admission and connecting to outpatient care within 30 days. Oops. This initiative is aligned with the greater initiative, which is Thrive NYC, a rather ambitious and really exciting initiative to really increase the attention and resources for mental health in New York City and for New York City residents. There's 6 principles that sort of underlie the Thrive NYC initiatives, which I hopefully are getting a lot of airplay right now, so people are familiar with. But the 2 that really apply to this program are Act Early and Closing Treatment Gaps. So in acting early, there's a body of evidence, a body of research that really supports that early intervention for psychotic illness is associated with improved clinical and functional outcomes, and enhancing early detection and referral mechanisms is one way to improve connection to care for this population so that they can receive some of those services and have improved outcomes as a result. And in closing treatment gaps, many adults with psychotic illness don't successfully engage initially in mental health services. Following a hospital admission, often there is a delay and multiple readmissions before somebody successfully engages in ongoing mental health care. So this program really tries to address treatment gaps that can occur in our system by facilitating access and supporting linkage to services that can reduce those gaps and improve the outcomes. To give you a brief overview of what psychotic illness in New York City looks like, it's estimated about 2,000 new cases of psychotic illness develop annually in New York City. Not all, but many of those resolved in a hospital admission. About 40 to 50% of individuals with psychotic illness receive ongoing psychiatric care, which was really the population that we were trying to reach. And without follow-up treatment, over 25% of individuals with first episode psychosis are readmitted within a year. There's something called a DUP, which is a very important part of first episode psychosis research right now. It's the duration of untreated psychosis, the time between onset of symptoms and initiation of adequate treatment. In the United States right now, the average duration of untreated psychosis is 1 to 3 years. So this initiative also wanted to look at ways to shrink that, as the lower the duration of untreated psychosis, the better the results for individuals. When the board amended the health code and added section 1104, this is a summary of the text of what that amendment contains. So the criteria for reporting is individuals over 13 and under 30 at 8 years of age admitted to a hospital with a with a psychosis diagnosis and with no known prior hospitalizations as an adult. The diagnoses are all of the primary schizophrenia spectrum diagnoses. It excludes 3 psychotic illnesses that aren't seen as effectively treated with early intervention services, and those are psychosis secondary to substance-induced, psychosis secondary to a medical condition, and psychosis secondary to a mood disorder. But all of the other psychosis-containing conditions are included in this provision. New York City hospitals are required to report admission of individuals who meet this criteria to the Department of Health and Mental Hygiene within 24 hours of, actually I think it says 24 hours of admission, but the reality is within 24 hours of admission, hospitals may not know whether or not this person meets reporting criteria. So really the way it's been operationalized is within 24 hours of recognizing that this person meets reporting criteria. And then this is how it works. So reports come in to the Department of Health and Mental Hygiene through a simplified and secure electronic reporting mechanism, which is Reporting Central. It's the same reporting mechanism used by hospitals and used by providers to report all reportable health conditions, diseases, and events to the city. We have an interface built on there specifically for first episode psychosis, and when hospitals report an individual, a specialized team, the New York City Supportive Transition and Recovery Team, responds to that report by contacting the hospital and assessing how we can go about offering this voluntary service to this individual when it's clinically appropriate to do so. When it's clinically appropriate to do so, which is a back and forth between us and the hospital for when they think this is the right time, our program goes out and engages the individual who's been hospitalized, their family if available, or other support system, the inpatient treatment team, and presents our program and offers our services. A person can accept our services, they can decline our services. If a person accepts our services, we start working with the individual at the point within their hospital admission so that we can maybe do some work around preparing for hospital discharge and promoting some specialized resources to the hospital that have emerged in the city recently for first episode psychosis. In the event that somebody declines our services, all identifiable information is voided out of our reporting system after 30 days, and we keep a very, very small de-identified data set for some analysis, but we didn't want to have a registry, and we don't. The team that provides services to those who agree is a team that grew over 2014 and provides citywide services as of 2015 with every hospital in New York City. It's an interdisciplinary team of social workers and peer specialists. For our purposes, peer specialists are individuals with lived experience as mental health consumers and additional training to use that lived experience as a clinical tool to help others. They utilize a critical time intervention case management model, which we actually developed specifically for this program. So it's a new model, but building on an established evidence-based model called critical time intervention. The feature of critical time intervention is it's focused around intervening during a critical time, so for our purposes, the onset of a psychotic illness and a hospitalization that results there, and on a transition. So for us, it's the transition back into the community. It's time limited, so our time limit is 3 months. So we continue for 3 months after discharge, and we work during that time to support linkage to treatment services and to enduring supports in the community. We, during that time, will collaborate with families and try to engage families or other support systems, as well as working to promote and help people engage in the specialized services that have become available in the city. There was some initial concern when the proposal was first put forward, which some members of the board may recall, from the hospitals about how having people from the city Department of Health and Mental Hygiene come onto their inpatient unit could potentially be disruptive. And there was concern that we didn't want that to in any way interfere with the hospital's relationship and with the treatment being provided in the hospital. So at the time that the program was launched, we offered hospitals some options on how to work with us. One was that when the reports came in, the START program could respond to all of the reports, go to the hospital and proactively offer services to every individual who met criteria. The other two options, which are really best condensed together into one, was to let the hospitals present the program to the patient themselves and let us know whether or not the person was interested in then meeting with us. Hospitals could choose to have done that across the board, or they could have chosen to do that on a case-to-case basis based on the clinical presentation of the case. I'm kind of happy to be able to report that all of the hospitals are having us come on board for now at this point, nearly all of the people. We've built a very positive relationship with the hospitals. They see us as a resource as opposed to as something interfering. And the only time at this point that we're not presenting at the hospital directly is if in a condensed hospital stay, the person is leaving the hospital before our team has an opportunity to get there and present, in which case we're presenting to the person in the community after hospital discharge. We do better with presenting directly to the hospital. This is from 2015, not currently, because really all hospitals are having us present all cases, but when hospitals were having some choices where they would say, well, we'll present the case and we'll let you know how that went, our acceptance rates were higher if our staff went out and presented the program ourselves than if the hospitals tried to do it for us. And really the response from the hospitals to our program has been, I think, very positive. So in terms of reporting, the program started in mid-2014 and it did a staggered rollout across hospitals as we built capacity for the remainder of 2014, really became fully operational in January of 2015. So to date, we've had 772 reports come in. There's a small table at the bottom which gives a breakdown of all of those reports. But what I like to highlight is over 70% of eligible individuals agreed to work with us. There are some folks who aren't eligible for the program. Those are people who either are found to not have the first episode diagnosis on further review by the hospital of their records and presentation, people who aren't planning on residing in New York City following hospital discharge are really our two populations that don't meet criteria. In looking at the people who have been reported into us, I think the takeaway really is that it's a young population. Peak age of onset for first episode psychosis is 25 years of age. Most of our people are 24 or younger. Oh, I think about 75%, 24 or younger. And in fact, nearly a quarter are 18 or 19-year-olds. For gender, reports coming into us are about 2/3 male, which I think is not a reflection on the reporting as much as it's a reflection on hospital admission practices. First episode psychosis should be pretty much gender neutral. The difference in first episode psychosis is that for women, age of onset, peak age of onset is a little later, and for men it's a little earlier. But really the gender should be about equal, so that we're seeing more men reported to us than women, I think is more a reflection on hospital admits being more heavily weighted towards men, and perhaps women are less likely to be admitted with a first episode of psychosis. In terms of diagnosis, perhaps as should be expected, the vast majority is psychosis NOS. So psychosis NOS means there's been a episode of psychosis, but it's unclear exactly what the cause is and the time frames that are involved in applying one of the other diagnoses haven't been met yet because this is a new onset of psychotic symptoms. And in terms of insurance, a little less than half of the people we're seeing are Medicaid recipients. And the other takeaway that I think is important on this is 11% of the people we're seeing are uninsured. And so it gives us, I think, a cause to help people navigate not just the treatment system, but how to access insurance correctly in this age of the Affordable Care Act and managed care reform. One of the central features of our program is to work on helping people connect to the complementary specialized resources that are emerging throughout New York City. When this proposal was put forward, I think there were 3 specialized programs available within New York City. There's now many more. Those are including On Track New York, which is a program for individuals 16 to 30 years old with the first episode of psychosis. They now have 5 locations in New York City, and there's a plan in 2016 to add 4 more. Parachute New York City, which is an initiative that was started actually at the Department of Health and Mental Hygiene with a federal grant to have specialized mobile treatment teams who would provide services to individuals 18 to 65. Has a nice evidence base that this is a good treatment resource for individuals with first episode psychosis. And 3 of those teams exist now, covering Manhattan, Queens, and the Bronx. There's also an early treatment program through Long Island Jewish and Lenox Hill Hospital, which has much the same criteria as On Track New York, but looks at, as opposed to duration of symptoms, looks more at whether or not somebody has had a very long period of treatment. In 2015, we were able to successfully connect 57 individuals to those specialized resources. Other people we worked with connected to treatment as usual in the community, and our goal is to really work on increasing the ratio of people who get specialized services, because we believe those specialized services have better outcomes associated with them. And I wanted to sum this up by trying to put a little bit of a human face on the people that we see and provide services to. So this is a brief case vignette that I will go through. It was picked not because it's extraordinary, but because it features many of the common themes that we're seeing in the people that we provide services to. So this individual is a 20-year-old African-American female. She's a student, and she was referred to us following a hospital admission. She was having hallucinations and delusions, and resulted in a hospital admission, the first one that she had ever had. During the course of the hospital admission, she was referred to our program and accepted services when we went up and offered services to her at the hospital. Our team was able to be involved with the hospital treatment team during the discharge and initial connection to outpatient services, which were traditional outpatient mental health clinic services. See a doctor once a month, see a therapist once a week. We did close coordination with the school to make sure that this hospitalization didn't interfere with her continuing her education, because that can often happen for individuals who have a psychotic episode, and we really want to prevent that whenever possible. Following a pattern which is not untypical for us, this individual started to disengage from her outpatient services shortly following her hospital discharge. She had concerns about the medication she was taking, whether or not these were the right things for her to take, side effects that she was experiencing. She had conflicts with her school schedule and saw the treatment as a barrier to her being able to do the things that were important to her to do. As she connected from these services, though, her symptoms started to reemerge, and it started to become a problem for her that created some housing crisis and some crisis with her being able to continue in school. In this scenario, we remained engaged. We were able to continue our engagement efforts with her. We were able to offer some real practical assistance around the housing needs. We were able to work really collaboratively with her family system around education and providing some additional family support, and really work with her and her family together to develop an understanding of how reconnecting with treatment could help with her recovery and with her goals for remaining in school and moving forward with her life. And at the end of this 3-month involvement, we had successfully re-engaged her in services. We had actually shifted her over to one of the more specialized treatment programs, which worked better for her. It was more flexible and better met her needs. She was engaged in school, did not have an interruption in school, and had managed to reconnect with a grandmother who she had had a period of estrangement from for the past couple of years, but was able to really re-engage in a supportive manner, and that actually helped with the housing crisis. So I wanted to sort of leave that as an example of some of the cases we worked with and some of the work that we find valuable, and would be happy to try to answer any questions that you may have.
Thank you very much. Open for questions.
Thank you very much. I just want to say I think this is extraordinary. But I recall when we discussed this several years ago, raising the issue of minors, particularly the 16 to 18-year-old group, and I don't remember exactly all the barriers to extending it, but I wonder if now that the program has been so successful over this time, as a pediatrician on the board, whether or not there's any way to expand this effort, which seems so tremendously helpful to so many people, to that group that also is in the group that has first episode, psychotic episodes.
Yeah, and that is a great question. At the time that the proposal was put forward, we were doing something brand new. It had never been done anywhere else. And there were some barriers to implementation around minors. And honestly, the vast majority of cases do occur between 18 and 30, but there is a number of people who have their first onset prior to age 18. At this point, what I would like to say to that is I think that we could easily implement this program for 16 and 17-year-olds. I think it would be a helpful and beneficial thing to do. And if there is a will for us to pursue that, I would be, very happy to work on how we could implement that. One easy way of implementing that, the reporting is part of law. And I guess the reporting requirements could be modified to include 16 and 17-year-olds, but certainly the program, the NYC START program, could accept 16 and 17-year-olds without any modification to the health code.
Thank you. And thank you for the question. We'll take that under advisement.
So,
First, Pam Breyer, and then Lucy Gill.
so in another life, I distinctly remember the day that this was approved by the Board of Health and the Sturm-und-Drang that went along with it on the part of some parties, not me, but others. And I'm thrilled to hear this. I think the collaborative approach really, of course, is what's made this possible. And I think you're right, now that there is more going on in the city of New York, thanks to the Thrive Initiative, certainly. But as looking to connect care of the mind and the body gets more play and becomes more popular as an idea, there are more providers who are really taking the broader view and looping in social services. And in the ideal sense, you would spark something that eventually gets picked up by the various PPSs around the city. Some of them do this in any event. And I do think that a role that you have here is not only the intervention in itself, but of course the education and the sharing with people of how to make this happen. This is just, it was unusual really for the health department to want to take on a direct service. Really an unusual step, and you've done it so well, and you are just to be congratulated, really. It's just great.
Thank you.
I also want to congratulate the department for this extraordinary initiative. I think it's the only one in the country that I know of. And together with Strive, what it does is taking New York City to take the lead in the country around mental illness. I'm delighted that you raised the issue about younger, or moving this program to early adolescence, which is supported, I think, by the literature in psychiatry. I'm just wondering whether you have data regarding ethnicity and race on the cohort of patients that have been treated. And then the other question that I have, if you have data about the housing status at the time of admission and then post-discharge, since we have a challenge in terms of the homeless population in New York City. But again, congratulations for a very well done job.
Thank you. And to answer your questions, race and ethnicity aren't part of the data set that we maintain for people who decline services. Perhaps unfortunately so, because I think it would be interesting to see that. It is something that we retain for people who accept services. So we do have data on race and ethnicity amongst those who agree to accept services. Roughly speaking, in looking at it to date, about nearly half are African American, about 26% are white. The remainder, I would actually have to look at the charts because I don't want to give inaccurate information, but I can certainly follow up with a more accurate breakdown. I think that is not quite reflective of the city's ethnic and racial breakdown as a whole. However, I don't believe it to be a function of the program. I think that we're downstream from hospital admissions, and I think it's known that there are some perhaps room to grow in promoting racial equity in hospital admissions and how people are admitted to an inpatient unit. In terms of housing, that is a great question. We do capture housing information and change in housing information on people that we work with. We have not analyzed that information yet, but I will because I think that's a great question.
Thank you. So I would note that you very nicely placed this in the context of Thrive NYC, noting that acting early is important and closing treatment gaps is important, but I think it goes along with other aspects of Thrive NYC. This is part of changing the culture. I really want to note for the board that you're not only looking at adherence to medications, but looking at the whole person and how they engage with their family, their community, and assisting in leveraging other social services that are available to them. So it really is a holistic approach, and of course it's an example of positioning government to lead. So I appreciate the feedback from the board. The note on 16 and 17-year-olds is one that we will take up and discuss. So I'd like to thank you for that really informational presentation and for updating the board today. Great job. Before we close, I would like to just note one more resolution on behalf of the board. And this one is to acknowledge Martha Robinson, who has worked as counsel in this department for many years. She joined the department in 1993, and today will be her last meeting of the Board of Health. So with the agreement of the board, I'm going to read into the record the entire resolution. Martha, I know you don't like to do this, but if you could please just let people know who you are by standing, and then you may sit down while I read. So this is a resolution of the Board of Health of the New York City Department of Health and Mental Hygiene, whereas since 1993, Martha Robinson has been a leader in developing proposals for review by the Board of Health in such varied areas as tuberculosis, daycare, food service establishment, and whereas Ms. Robinson represents the very best in the health professions, having spent her professional career working on health-related matters, and whereas, as an expression of its deep appreciation of Ms. Robinson's service and extraordinary commitment to improving the health of the residents of our city, it is thereby resolved that the Board of Health and all of its members congratulate Martha Robinson on her retirement and extend to her their heartfelt gratitude for her dedicated service to the City of New York Board of Health and the Department of Health. Thank you. So to the General Counsel, Tom Merrill, perhaps you'd like to add a few more words.
Martha sits in my office, and she's been, Roz can't be here, couldn't be here today because of a preschool graduation, I believe. And otherwise she would have been here. But you've been our right-hand person, and we're going to, as much as I've enjoyed sparring with you over the last 10 years that I've been here, and I knew Martha, she's probably the first person I met in the department because I knew her at the law department. You know, she's a huge loss, and we're going to miss her. And she's promised to still be in touch, and I'm going to take her up on that. Thank you. Congratulations.
Congratulations, Martha, and thanks for a job superbly well done. Also, I, with sadness today, announced the departure of Dan Cass, who is the Deputy Commissioner for the Division of Environmental Health. He's planning to leave the agency by the end of August after more than 15 years of service. This is a great loss to us as an agency as a whole, but I bring it to the attention of the board because the division which he's led has played such a critical role in the regulatory activities of our agency, and he's so often come before you to present, as he and colleagues did today, path-breaking proposals to make our city safer and healthier for all its residents. So this will be his last attendance at a Board of Health meeting, and I'd like to personally convey my gratitude to him in his many roles, including his role in ensuring that our health code is always the best position to ensure that we have a healthy city, from our food to our daycare to the air we breathe and so on. Thank you very much, Dan. And with that, if there are no further comments from the Board of Health, I declare the meeting adjourned. Thanks to all those in attendance.
Mila.
Congratulations.